Good morning, everybody. I'll just give it another minute or two just to see if more people are joining in. Okay, I'll start. Good morning, everybody, and I'd like to welcome our panelists today and our speakers, as well as all of our audience, to today's carer webinar, our carer harm webinar. This is the second of two webinars that are co-hosted by Family Carers Ireland and UCD. So my name is Dr. Nikki Dunn. I am the research manager with Family Carers Ireland. And for those of you that don't know us, we are the national organisation supporting family carers across Ireland. So we are a not-for-profit organisation supporting family carers and young carers through the provision of a wide suite of supports and services, such as counselling, specialised training and education programmes, emergency respite, advocacy, peer support groups, information, rights and entitlements, and research, of course, as well. So we've worked with Dr. Sarah Donnelly from UCD over the last 2 years on a piece of research that was funded by the Irish Research Council's New Foundation grant scheme. It was a small piece of research examining the issue of carer harm. And this, Sarah will go into more detail about what this concept means, but in a nutshell, it's carers who are experiencing harm in the context of their caring relationship. So the research has shone a light on a very hidden aspect of the caring experience, but one that we were seeing coming through on the ground in terms of the supports that we were providing carers. So we're very grateful to have worked with someone like Sarah on this project. She's brought a huge amount of empathy and sensitivity to what is a sensitive topic. So like I said, this is the second of two webinars which have focused on the topic. The first one looked very much in the Irish context and from family carers' perspectives as well, where this webinar is exploring it a little bit more in a broadened context, so much more from a global perspective, and you'll see that by the profile of our speakers and our panelists. And again, it's very heartening to see so many people here today, and there's clearly an interest in this topic. So before I introduce the speakers, I just want to share a few housekeeping notes then as well. So we've scheduled 2 hours for this morning, and Sarah is going to present for half an hour or so and give a detailed presentation of the Carer Harm project, and there'll be some time for Q&A afterwards. And then we'll move on to our second speaker, Amanda Warburton-Wynne, who will also kind of explore the topic from a different perspective. We'll move on to a panel discussion with 4 speakers. And again, there's going to be some time for Q&A built in here. So each of the speakers have been asked to reflect and respond to the 2 presentations. So you'll notice everyone's mics are muted and the cameras are turned off. And this is intentional just to keep the focus on the speakers today. And we do have time, as I said, for Q&A after the 2 talks and after the panel discussion as well. And you can submit your questions via the chat or use the hands up function and we can unmute you. Now, just be mindful today as well that we have an international audience and international panelists. So if you're asking questions, it would be useful if you could give some sort of explanation or a little bit of background to the context that you're asking your question in. So we are recording the presentation today and we will circulate it to all attendees afterwards. And we'll also be uploading it to the Family Carers Ireland website. And we also ask if any of the attendees could change your Zoom name to your name and organisation. That would be very helpful just for the Q&A part of the webinar this morning. So with that, I would like to introduce Dr. Sarah Donnelly. So Sarah is an assistant professor of social work at the School of Social Policy, Social Work and Social Justice at UCD. Sarah is co-convener of the European Network for Gerontological Social Work and academic advisor on adult safeguarding to the Irish Association of Social Workers. And prior to working in UCD, Sarah worked as a medical social worker for 15 years as a social work team leader in the age-related healthcare team in Tala University. So Sarah has published widely on adult safeguarding, aging, dementia, care planning meetings, capacity and decision making, and is a passionate advocate for human rights and social justice. So over to you, Sarah. Thank you.
Thank you very much, Nikki, for the lovely introduction. I'm presuming you can hear me okay, or everyone can hear me okay. So look, I'll just try and share my screen and then we can get started. Okay, so as Nikki said, this is webinar 2. This is a follow-on from our previous webinar a few weeks ago, where I also presented these findings, but I suppose for this morning, I want to present them. Obviously, we have a different audience and our focus is very different in terms of broadening out our conversation around this really important topic of care harm. So firstly, look, I wanted to just start off a little bit in terms of defining what care harm is. And I suppose also before I get into this, I should acknowledge firstly and thank Family Carers Ireland for their ongoing support and partnership around this project, but also to thank sincerely Dr. Marita O'Brien, who was the postdoctoral researcher and co-authored the report itself. So look, care harm itself is not a concept that is well known or well understood by many professionals and service providers. But really, I suppose one of the few working definitions we have is from Isham et al. Have done some work in the UK context around care harm experienced by carers of people living with dementia, who define it as being when carers experience violence or become subject to controlling or coercive behaviour, whether that's on an incidental or a systematic basis, which ultimately results in physical, psychological and/or sexual harm. And again, I suppose the motivations for both myself and Family Carers Ireland to really look at this topic stemmed from an earlier study that was carried out by Family Carers Ireland, the College of Psychiatrists of Ireland, and Dr. Deirdre O'Donnell in UCD, which really showed, quite startling figures in the survey that 44% of all carers reported regularly experiencing physical aggression and or emotional and psychological harm within the context of their caregiving. And again, I suppose we're very aware of the significant negative impact that this can have on caregivers' health and well-being, but also kind of the long-term impact on those who experience abuse or harm. But I suppose ultimately, and why we wanted to try to find out more about this, is we really don't know a lot about this topic. Again, we're very fortunate to have Amanda, who's going to be talking after me this morning, who has done some work in this area, but really it's kind of, there hasn't been a huge amount of research done. So really, I suppose our hope was to try and shed light on this a little bit more, both in terms of family carers' experiences of carers harm, but also really to try and dig into professionals' experiences of navigating and trying to support those experiencing carers harm. Because really we know that there have been professionals who have really struggled with this, and there have been calls for people to work, I suppose, more proactively together around this. So as I said, really the 2019 study very much it's concluded that the impact of physical and verbal abuse in family carers remains hidden and under-researched, and the further research needed to be done. So this is our research design for the care harm study that I was involved in. And I suppose ultimately, as I said, we wanted to look at what are the perceptions and experiences of family carers of experiencing care harm, and how can they be better supported by health and social care professionals or service providers. So the first part of this project was secondary data analysis of qualitative comments from the 2019 survey, which I'm not going to go into the results of that today. Ultimately what it showed was a significant need for additional training for family carers, but also, when we dug into that data, what it really showed was that there was 2 cohorts of family carers who were particularly impacted by the experience of care harm, and that was carers of children or adults with autism and carers of people living with dementia. Our second work package then involved narrative interviews. And again, I suppose important to acknowledge this is a really small sample size, but nonetheless, I think it's given us really valuable insights into some of that lived experience. So we carried out narrative interviews with 5 family carers of children or adults with autism and 4 family carers of people living with dementia who had self-identified as experiencing care harm. We also carried out one interview with 2 autism education providers and 1 of Family Carers Ireland senior managers. To complement and I suppose really to try and get the professional perspective, we also carried out 3 focus groups, one with a group of Family Carers Ireland case support managers, one with a group of autism professionals and one with dementia professionals. And again, all of this, I suppose these findings then fed into work package 3, which was what we call a World Cafe co-design workshop, where essentially we brought together family carers, advocacy organisations, and professionals to really look at the findings that were emerging and looking at how we could, I suppose, translate these into a tangible output that might help better support family carers and professionals navigating this very, very difficult situation. And again, I think for myself and also for Family Carers Ireland, it was really important from the outset that this just wasn't a piece of academic research, which is of course important, but we really wanted there to be some type of tangible outputs that people could really use that would hopefully heighten awareness, but also better support both family carers and professionals. So I've kind of gone through the narrative interview piece in terms of the focus groups. As I said, focus group 1 was family care support managers. In terms of the autism focus group, we had a variety of mostly social workers, so social workers from our Child and Family Agency here in Ireland, Child and Adolescent Mental Health Services, our safeguarding and protection teams, but also social workers from disability service providers. In terms of the dementia focus group, again, that was a little bit more diverse in terms of the professionals who participated. So we had medical social worker, dementia nurse specialist, dementia advisor, advanced nurse practitioner, and also an occupational therapist. So again, just to give you a little bit of an insight into the profile of the narrative interview participants. So again, we had a variety of parents to either adult children or children under 18 who had autism and who they were the primary carer for. And again, in terms of our dementia narrative interview participants, again, it was all female interviewees. And again, some were 3 were daughters and 1 was the wife of the person living with dementia. Again, we did, I suppose I should have said this at the outset, we did struggle quite a bit to identify participants for the narrative interviews, but I think that was a combination of, I think, the topic and people maybe not feeling entirely comfortable coming forward to talk about it, but also I suppose we were working within very tight timeframes in terms of the project and budget, so that also kind of impacted on our recruitment strategies. So in terms of the key themes that emerged from the narrative interviews and the focus groups, I suppose first there were 3 kind of overarching themes, that the whole issue of how we understand care harm, how do we define it, but also within that stigma, shame and guilt. Obviously, unsurprisingly, the different types of care harm experienced. But I suppose interestingly, one of our main themes was expectations, responses and systems that harm. Our second kind of major theme was around how do we protect family carers who are experiencing care harm. And again, within that, a key theme, which I'm not going into today because of time constraints, was really that whole issue of diagnosis and early intervention as a critical juncture within the caregiving journey, but also that the whole issue of transitions and changing care needs, for the children with autism, the whole onset of puberty is kind of a really, really challenging period, but also for people living with dementia, for their family caregivers, changing or increasing care needs sometimes being a period of quite challenging behaviour or difficulties managing some of those emerging complex care needs. What also emerged was the whole issue of both professionals and family carers trying to navigate a very fragmented and complex health and social care system here in Ireland, but also professional helplessness and really an inability to respond in many situations. And then finally, I suppose we have to look to the future and to the positive, really there was a strong focus as well on what helps and what else might help in these difficult situations. Okay, so I suppose firstly, understanding care harm. I mean, family carers and professionals articulated very strongly, real difficulties with defining and understanding this terminology. Again, the term not being instantly recognizable, not being well understood or regularly used in the everyday language of either professionals or family carers. And, as we move through the data analysis, I mean, we struggled, and I think we still struggle with whatever I don't know that there's a correct terminology, but the most acceptable terminology or the most representative terminology. And again, I'd be really interested to hear your thoughts around this once we move into the panel discussion, because we're not sure we've kind of, I suppose, come up with the accurate terminology as yet. And again, this was very much reflected by our participants. So an autism focus group participant reflected, this is not willful abuse, like it's abuse, but within the context of that person's autism and responsive behaviours. A dementia professional reflected, when we think of care harm, again, I struggle with the language. And I was thinking in my own head when you were talking, what other language could be used? And I don't know. Finally, a Family Carer Ireland focus group participant talked about, some people I find would never describe it as care harm. They would never use that word, I feel. So again, there was, people were really, really, I suppose, conflicted and found it very difficult to articulate what the correct language for these situations and these harmful behaviours were. I think one of the, I suppose, most striking findings from the study was the whole issue, hugely significant impact of stigma, shame and guilt, and really that being a significant barrier for family carers in disclosing their experiences of care harm. Again, family carers talked about the huge guilt that they felt talking about this, feelings of being disloyal to the person they cared for, but also a huge barrier being the fear of the consequences of disclosing that they're experiencing care harm. So that fear of unwanted and unwelcome interventions, and that was a very real lived reality for many of our family carers. So Katrina, one of our autism carers, talked about, carers don't talk about it. I think there's a huge stigma around, there's a huge silence. I mean, I haven't told most people what I've told you this morning, and even when I'm talking to other carers, we don't talk about that, it's taboo. A dementia focus group participant, meanwhile, reflected, I find that when I do have carers wanting to talk to me and share their experience, they're very apologetic. Please don't judge me. They feel they expect me to judge them because they're talking about that despite trying to build this open relationship. So certainly it's almost like guilt, so much guilt, that I should not be disloyal to my loved one for discussing this. So again, we can see those feelings of guilt, those feelings of disloyalty, and that very much feeding into that, I suppose, that reluctance and that kind of anxiety about disclosing. Again, family carers talked about a huge range of types of care harm that they had experienced, and this ranged from shouting, screaming, damage and destruction of personal possessions or the family home, but also for some family care, significant levels of physical violence, as well as the obvious knock-on emotional and psychological distress that caused. Again, huge, unsurprisingly, impact on their own health and well-being, as well as in particular for autism carers, impact on other siblings or young children in the house, which we'll talk about in a moment, and in relation to the dementia caregivers, impacts on other family members. So again, that might be other adult children in the home or indeed younger children. Professionals also described types of harm that they had experienced in supporting family carers. And again, that very much mirrored the family carers' experiences in terms of physical aggression or assaults, emotional toll, and impact on the family carers' mental health and well-being. So again, Nolene, this quote from Nolene, one of our autism carers, I think very much illustrates the reality of this for many of our family carers. So in relation to Nolene's daughter, she talked about she would beat down the door. She's broken the door about 3 or 4 times. And when she can't get at me, she will break everything and has done it, break everything that you see in the house. She's broken televisions, computers, laptops, and she'd break things belonging to herself. She's broken her Nintendo Switch 3 or 4 times, cups, plates, stand on them with no shoes on. So I'd end up having to bring her to accident and emergency. So again, I suppose what we can see there, both the physical impact in terms of Nolene's own daughter's well-being, in terms of all of this destruction, but also the huge impact and destruction on the family home and personal possessions. Jennifer's story is Jennifer's a dementia carer, so she talks about, so some nights she's screaming outside my door, she's confused, and she gets agitated in the middle of the night. So some nights I could be up all night with her trying to settle her and get her back to bed. And obviously she comes in up screaming and that wakes up the kids. So some nights are awful. Some nights are good now and you can get your full night's sleep, but it's like having another child in the house. I have a baby monitor there. You nearly want a camera system in the room to make sure she doesn't do something she forgets about. So again, we can see in Jennifer's case, there was impacts not only on Jennifer, but also Jennifer's younger children who also lived with herself and her mum. I think for me, one of the more surprising findings from the study was the whole issue of systems and responses that harm, and really this being an issue not only for family carers, but also for the professionals as well. So family carers reporting the challenges of navigating a very fragmented and complicated health and social care system here in Ireland. As I said, the whole issue of diagnosis and early intervention as a critical juncture. So family carers really identifying gaps in terms of that ability to get an early diagnosis, to get those early intervention services. And I suppose that the subsequent negative knock-on impacts down the line because of those delays. Professionals, interestingly, also spoke about the unrealistic and often unhelpful societal expectations and pressures which were placed on family carers, which were often considered as a contributory factor in the harm the family carers experienced. Again, there was this kind of general expectation that the whole family would provide the necessary care, and this included other children in the family acting as caregivers. So in other words, young carers taking on that caregiving role. Again, here in Ireland, the significant lack of clarity around who's responsible for providing supports and services to autistic children and adults really led to many falling between the services. And for all of our family carers, they really recounted the experience of constantly having to fight for and beg for help in order to stay safe. Again, I suppose for many professionals, they also reflected on their immense feelings of helplessness and frustration, and their really inability to respond, even in very significant crisis or even life-threatening situations. And I suppose, again, the professionals could really recognise and made the link between care harm and the absence of appropriate condition-specific responsive services. Okay, so again, this is again illustrated by some of our quotes. So on autism, focus group participant reflected, there's no proper tracking. We get really frustrated. We get this all the time. Oh, they've autism, that's great, but that doesn't mean they need disability services. They're mild to moderate intellectual disability, so they should go to the primary care team, which is our community-based teams here in Ireland. Primary care, whoever say no, that's the social inclusion team. So you go to social inclusion and they say no, that's primary care. If you look at the points that the person has gotten for their intellectual disability, sometimes it's actually moderate, but we have people who have different scales of what's mild and moderate. So again, family carers and professionals talk about different services having different thresholds or different, I suppose, access criteria, which again made this whole, I suppose, compounded this already very, very difficult situation. I think Paula and Sean's quote again is very telling in terms of the unhelpful attitudes. So they talked about the disability officer was in the health service executive. She is charged with getting families like ours something if it's just gone to complete rock bottom and the family can't cope. And we were told as well, which wasn't helpful, you're not the worst case. There's a lot worse than you out there. And again, many of our family carers talked about this sense that they were made to feel like they were undeserving and that there was this hierarchy of need in terms of only those with the very, very high level needs or the very, very highly dependent on children or adults were entitled or should get any service provision and support. I think probably one of the most distressing and upsetting quotes from our family carers is that from Lana, and I think it really illustrates the lived reality of some of these very difficult situations and dangerous situations for our family carers. So Lana talked about when Dee was about 9 years of age, I was home on my own. My husband was in work and he came back from school and he had a tremendous meltdown and he pulled my hair, even though he doesn't usually do that. But that day he did. He pulled me with such force that I hit my head on the ground and I was there for a few seconds. And then my eldest child came home from school. So you can imagine Dee was 9, so my eldest was 11. Can you imagine what it's like for an 11-year-old child to restrain his brother on the sofa to give me a chance to get up? I remember this to the day I die. Like my eldest was crying. He was saying, Mummy, I don't know for how much longer I can restrain him. And again, this speaks so strongly to that significant impact on other siblings and children in the house. And Lana's experience was not an isolated one in any way in terms of that. Other family carers talked about having to make safety plans really in order to keep themselves and other family members safe. But again, parallel to that, we had our professionals who really, even in these often life-threatening situations and, very, very crisis situations, had no way to respond. So one of our autism focus group participants reflected, so we see it from all ends, the guards, the police ring us. Sometimes we have the guards close to tears saying, what am I supposed to do? And in extreme cases, we will do a call. We will say, you have to bring him to hospital. You have to section 12 them, which is where the child is brought to a place of safety and bring them to the hospital because we don't have a placement for them. So again, this was a very strong repeated theme around, even, as I said, in these very crisis situations, no ability to access respite or any other support services. And more often than not, the response was to try and remove the other children from the family home rather than the child who was causing the harmful behaviour, which again was not welcome or wanted by either family carers or professionals. In other instances, some of these behaviours were criminalised. And again, this was kind of social workers or other professionals working within the confines of our current policy framework. But again, everybody really kind of acknowledging that these were not helpful or wanted responses. So look, I suppose I've really skimmed the findings. There's a lot more depth and detail there in the full research report. So look, I'd really encourage you to go off and read that in your own time. For the final part of my presentation, I'm going to look at what helped and, really what came out of the findings and the World Cafe in terms of what might better help and support family carers experiencing care harm. So again, unsurprisingly, well, services, obviously, I haven't included my slide in services, but condition responsive specific services, early intervention, obviously were critical, but also advocacy. So for many of our family carers, they had to be quite creative to get any types of support, and often that involved, maybe engaging with politicians, with the media, with social media. So again, that recognition around family carers needing support around some of these advocacy interventions, support around letter writing, identifying who power holders are, and really getting support from professionals so that they could advocate on behalf of themselves. Again, the need and that recognition of the need for more routine and proactive assessment of family carers' support needs, their coping capacity, and really the impact of caregiving on their overall physical and mental health and general well-being. There was an acknowledgement that, I think collective advocacy, collaboration, building more links at the community level, and signposting people to what resources are there, that they would be pulled to avoid duplication, more clear referral pathways, but also, what came through both from the professionals and some of the family carers as well, they didn't welcome the criminalisation of some of the harmful behaviours. The community Gardaí or community police actually played a really important and helpful role in some situations in terms of either kind of calming the situation, being a support out of hours when there was nobody else, and really that kind of support could probably be better harnessed and utilised. Again, unsurprisingly, the need for more education and training. So the provision of condition-specific information, training and knowledge on the presenting disability or condition is essential. And again, our dementia caregivers and professionals talked a huge amount about the importance of, again, that early diagnosis, but also the need to know what type of dementia a person has so that they can educate themselves around what types of behaviour to expect along the disease trajectory. But often, again, similar to the autism carers, that didn't happen in a timely way. Again, I suppose for the family carers and professionals, there was a recognition and an acknowledgement that often family carers in these situations are quite isolated within their experience, and that peer support groups for family carers, community-based support groups could be hugely beneficial in terms of providing that safe space that people could share concerns around their experiences of care harm. And then I suppose, again, unsurprisingly, the need for a whole wraparound family support service. So the provision of family therapy that really focuses on the whole family unit rather than individuals within that, would allow family members to voice their worries, concerns and wishes. And again, for autism family carers, that need for kind of intensive play therapy for younger children. And again, for carers of people living with dementia, that need for counselling and support on an ongoing basis was very much highlighted. So this is our, as I said, at the outset, we wanted to develop, I suppose, tangible outputs. These are all available both on the Family Carers Ireland website as well as the UCD research repository. But we have our research report on the left-hand side. We have developed an information leaflet specific to care harm generally, but also one specific to care harm within the context of autism and dementia. And then finally, a best practice considerations guide for health and social care professionals, which again, we hoped might better support and prepare them to help and support family carers. So again, I would encourage you to check them out in your own time, and we'll also share them with all attendees after today's webinar. So I suppose just moving into the discussion then. So as I said earlier, a diagnosis of autism or dementia did not automatically bring with it the services for the child or adult being cared for, nor indeed support for the family carer, even when family carers were experiencing significant and in some instances life-threatening harm. I think, again, we have particular issues here in Ireland at the moment in terms of our disability services, issues with staffing, staff turnover, but all of these fed into services often taking a silo mentality, imposing strict diagnostic categories for access. So this resulted in families living with the risk of harm as the child or adult exhibiting the harmful behaviour was not getting any professional input or support. Again, I think ultimately there was a failure in many instances to acknowledge and address that family carers themselves, other siblings, other family members also have a right to live in a safe environment. And again, I think this is where our current policy and legislative framework is very problematic, because I think that recognition of all individual rights isn't really attended to in terms of our current responses and referral pathways. Again, Dr. Declan Coogan in the University of Galway here in Ireland has done some really interesting and important work around child-to-parent violence. And again, his work would kind of suggest that many parents who are assaulted by their children either unsurprisingly deny or minimise it, or often blame themselves for their children's behaviour. Again, parents fear blame from professionals who often also can either minimise or excuse the child's harmful behaviour. And I think ultimately the crux of this for me is that conflicts exist for many professionals in relation to balancing the needs, safety and protection of all family members and taking that whole family approach. So again, in the Irish context, the outcome of mandatory reporting regarding the safeguarding of children and mandatory referrals in relation to those who might be defined as vulnerable adults often resulted in lots of paperwork and stress for parents and carers, but ultimately little meaningful action either to protect or to provide vital services and supports, which would help to reduce, eliminate risk and harm being experienced. Again, as I said from the outset, look, we really don't feel we've kind of gotten our heads around the language piece properly. Some of the other suggested terminologies were carers who have experienced harm or carers who've experienced harmful behaviours, but there may be better phrases that we need to consider and engage with. I think again that study showed, the whole issue of shame and isolation, which often can prevent people or act as a barrier to seeking support. In Ireland here, I think one of our major challenges is the lack of a legislative underpinning. Firstly, for children and adults have a right to a disability assessment, but they don't have a right to the resourcing of the recommendations of that disability assessment. Likewise, people living with dementia in Ireland have a statutory right to nursing home care, but we currently do not have a statutory entitlement to home care, which is extremely problematic. And again, for the family carers themselves, that statutory right to a standardised assessment of need in the Irish context is of ongoing concern, that gap. I think for me, and again, some of this is drawing on previous work I've done around safeguarding, effective protection and safeguarding needs to do more than waiting for a situation to reach a crisis point. And for me, again, we don't have primary adult safeguarding legislation in Ireland, but legislation like this would have the potential to empower the agency of professionals. So, for example, something like a duty to provide assistance would enable professionals to put services in place, particularly where carers are struggling and under threat. Again, I think, participants' experiences and professionals also suggest that we need to consider the more sophisticated concept of human interdependence. And again, Toronto has done some lovely work around this, but also recognising that interdependent nature of everyday living and caregiving when dealing with carer harm. Okay, so just to sum up, carer harm remains poorly understood and taboo topic with uncertain and inconsistent responses, both from professionals and services. However, as our understanding develops, the hope that we can better support family carers and the people they care for effectively and non-judgmentally grows. However, continuing shame and fear of being blamed means that family carers may not come forward for help until the situation is a crisis point, and indeed, some may not identify the problem as harmful or abusive themselves until this point, particularly where a child or an adult's disability appears to be the significant cause. Finally, those who take on significant caring responsibilities and who experience care harm should have the certainty that the necessary services and supports will be provided in a proactive, preventative manner, and that services will be put in place to help them maintain their own health and well-being, as well as that of their whole family unit. So look, I'd just like to thank Nikki again for her ongoing help and support, but also Sue O'Grady and Joanne Murphy from Family Carers Ireland for their help with the preparation of the research report. I also need to thank the many individuals who provided feedback on the draft booklets, and in particular, the Alzheimer's Society of Ireland Dementia Care Campaign Network members. Again, need to thank and acknowledge all of our steering group members and also some of our staff in UCD. But ultimately, and most importantly, we would like to sincerely thank and formally acknowledge all of the family carers and professionals who participated in the study. You've helped us to better understand what it's like to experience care harm, the challenges that there are to supporting family carers who are being harmed, and really without your involvement and participation and sharing your experiences, the study wouldn't have been possible. So my sincere thanks to you all. And other than that, I'm happy to answer any questions we might have. Thank you very much.
Thanks very much, Sarah, for that very comprehensive overview of the research and the findings. And again, it is really hard to believe that it was such a short research project. I think the findings and the outputs are so impactful. So I'd like to open the floor to queue for a couple of questions here that Sarah can answer. I see Kate Healy has her hand up. So Kate, if you would like to unmute yourself and you can ask your question.
I think we might have to unmute Kate, Nikki, or Rory.
Okay.
Sorry, Rory. Can't hear you. Let me see. Kate, you should be able to unmute yourself. Try to unmute. No? Not working.
Okay, Kate, you can keep trying to maybe unmute yourself or else put your question maybe in the chat box, Q&A. Are there any other questions for now?
We might have some later.
We might have some later. Maybe Sarah, I can ask you a question. Just I know that it came up kind of in it's kind of there, but it's you weren't kind of explicitly talking about it, just around some of the financial costs that are involved in the topic of in care harm.
Yeah, and look, I didn't really go into that in today's presentation, Nikki, but certainly we went into a bit of detail around that in the last webinar, and from the findings, it definitely was a significant issue in terms of, as I said, financial implications stemming from, destruction to the family home, destruction of personal possessions and property. And, you can imagine when that's happening on a very regular basis, that the huge financial burden that could be to a family caregiver. I think the other financial implications stemming from some of this care harm behaviours related to, things like, families maybe having to pay privately for an initial diagnosis, or indeed in the absence of services, having to pay for private carers, whether that's for a child or to an adult, in the absence of those kind of community-based, publicly provided services being available. So, yeah, I think we might have
We have a question in from Ashland there. I don't know if you see that, Sarah, but it's
yeah.
You mentioned a lack of legislative underpinning in Ireland. Are there any plans to change this?
Oh, that's a fantastic question. I think there's lots of plans to change it. I think the question is when that change will happen. I mean, our government has been talking about our statutory entitlement to home care as far back as I can remember, and certainly around 2015, 2016, there was a huge move on that. We're still awaiting that. Our understanding is that is in track. Similarly, there have been multiple calls for the need for primary adult safeguarding legislation. And despite numerous scandals here in Ireland, that still has not, we have draft legislation, but that's not currently being progressed in any active way. So we're still very much at, our safeguarding and protection social workers, other social workers are really operating in a bit of a legal lacuna because of that. And again, I'm not sure in terms of the disability assessments, whether there even is conversations around a legislative entitlement to those assessments being fulfilled. Somebody else may have more knowledge on that, but I mean, that legislative gap is significant. And unlike, I suppose, our colleagues in the UK, we don't have that concrete legislative underpinning that would really, I suppose, help provide the services in some of these situations.
Sarah, can I just follow up on that then and ask if you think that safeguarding legislation is the best kind of legislation to support carers who are experiencing this? Like, is that the way forward, or
not? I mean, I don't think it's the answer, but I think our current safeguarding lack of legislative framework, and I suppose because we're still operating in a bit of a policy kind of ambiguity in terms of we're operating off our 2014 policy. I think it would help. But again, I feel very strongly that these situations shouldn't really be going down the safeguarding route, even though there's obviously safeguarding issues. For me, that these situations would be better and more appropriately dealt with by our community-based primary care teams. And again, that's because I think that whole family approach needs to be taken rather than the very fragmented service approach we have at the moment, where you might have multiple services kind of involved around a particular family.
Great, Sarah. I'll leave it there then and we'll move on to our next speaker.
Yeah. Well, Nikki, you're mute.
Sorry, I put myself on mute. Again, there will be more opportunity for Q&A for Sarah later on if anybody has any questions. So I'd like to move on to our next speaker, Amanda Warburton-Wynn. Amanda, thank you for being here with us today. Amanda is an independent consultant and researcher in domestic abuse and sexual violence in the UK. She's a particular interest in people with disabilities and older people who have experienced these crimes, and she's several research papers published and been a guest lecturer for Birmingham City University, and she's been a speaker at Age UK safeguarding events. Amanda also works for the local authority, where she leads out on communication and awareness around domestic abuse and sexual violence. So Amanda, with that, I'll hand over to you. Thank you.
Thank you, Nikki, and thank you both of you, Sarah as well, for inviting me to come here today. Can I just check, can you see the presentation that I'm showing on the screen?
Yeah.
Yes, we can.
Yeah, great. So first of all, just to introduce myself and why I've been invited here today. So as Nikki just mentioned, I work for Cambridgeshire County Council local authority in England, and I'm part of the Domestic Abuse and Sexual Violence Partnership here. But outside of my day job, I also am an independent researcher and consultant around domestic abuse and sexual violence. And I've got a particular interest in people with disabilities, physical and learning disabilities, and older people. So I first came across this topic of carers and abuse during my day job. Started to write some papers on it independently, but I've actually been lucky enough that my employer has allowed us to start a project in Cambridgeshire looking at the issues that carers are experiencing. I just wanted to have a quick word about terminology as well, as Sarah just said in her presentation, that wording and how we name things is quite important. I'm actually going to be talking about unpaid carers and domestic abuse. And the reason that I'm using those terminologies is because as part of the project that I'm running, I actually spoke to our local carers partnership board, which is made up of carers, and I asked them what they thought the wording was that we should use. We did consider using family carers, but they felt unpaid carers was more accurate. We also spoke about whether we should refer to carer harm, but the feedback from the carers was that we're actually looking at domestic abuse in the main as deliberate abuse. So they felt that it should be named as domestic abuse. So that's why my presentation is talking about that rather than carer harm. And also, as regards to people who are doing the abusing, I will talk mostly about abusers, although there is one section which includes some official data around crime, and there I will refer to perpetrator, but usually it's abuser that I'll use. And also just to say that the work I'm doing at the moment doesn't cover child-to-parent abuse or abuse of young carers. And it's not that they're not an issue, it's just that my work isn't covering those at the moment. So the UK government has some legislation, the Care Act, which came out in 2014. And under that, it describes a carer as someone who helps another person, which is usually a relative or a friend, in their day-to-day life. And it also mentions that it's where the person can't cope with their daily living activities without the help of that person. So as regards identifying how many carers we have, Carers UK, who are a carers support organisation, in their last estimate from their annual survey in 2022, they estimated that 1 in 5 people were carers and that 58% of those are female. They are currently running their 23 survey at the moment, so there might be a slight change in these figures, but I don't think they're going to change hugely when they release the report on that. And there is also an issue around carers allowance that is paid by the Department of Work and Pensions, which could have an implication as to how many people actually identify as carers. So in order to receive the carers allowance benefit and payment, somebody needs to be caring for 35 hours a week, and that's however many people you care for. So we do know that some carers care for more than one person, and the person that you're caring for must get certain benefits, and also the carer must be earning £139 or less per week, which is obviously an issue if somebody is also working and caring. And also each cared for person, only one carer can claim for them. So there could actually be 2 family members looking after somebody, but only one of them can claim carers allowance. And also you can't get the full carers allowance and state pension at the same time. So there are a lot of restrictions. Even if you meet all that criteria, you actually only get £76.75 a week. So in terms of the number of people who are identifying as carers, the Carers Trust say that most carers don't actually identify themselves as carers. They see themselves as wife, husband, child, or another family member, and they wouldn't actually use the term carer to describe themselves. And it does then bring a question as to whether the carance allowance threshold of doing at least 35 hours a week impacts on whether people consider themselves as carers or not. So some of the reasons that people might need care is things around physical health, learning disability, people with mental ill health, and that can include illnesses like dementia, and also people with substance addiction can also need carers. So this list isn't exhaustive by any means. Some of the things that a carer might have to do are things like personal care, cooking, helping with benefits, also administering medication. Emotional support is a big part of caring. From the groups that I've spoken to, particularly people who are caring for people with mental ill health, I find that emotional support, it takes up quite a lot of their time. And obviously, if you're caring for more than one person, you could have double these duties. And it's also worth considering that for all these different caring tasks, if somebody was working as a paid carer, either in a care home or for a care agency, they would actually receive training on these. They would have training on delivering personal care, on medication administration, and also around working equipment such as hoists and things like that. Obviously, when somebody becomes an unpaid carer or a family carer, there isn't any training for that role. They're just expected to pick it up. There is things like support from occupational health or assistive technology that can come in and show how to use equipment, but that often takes quite some time to sort out, particularly if somebody is sort of discharged from hospital and is discharged needing care. By the time these things are in place, that can be several weeks that the carer is trying to manage that care on their own. So in 2021, the UK government released the Domestic Abuse Act, which was really the first legislation around domestic abuse, and it's explaining who was covered by the Act and what types of behaviour it covered. So it covers things such as physical and sexual abuse, which I think physical abuse is one of the most recognisable forms of domestic abuse. But when we think in the context of giving care, that's not always the more obvious things. Actually, things like hitting the person who's caring for you, pinching, biting, kicking. And it shouldn't be assumed that because somebody has care needs and maybe has some physical disability or mental health issues, that actually they aren't capable of inflicting significant physical harm, because they very much are. There's also controlling behaviour, so that can be in the context of caring, things like no time to attend appointments, or if they do go, the cared for person needs to be with them as well, so they can't seek any support. There could be implications around decision making and not allowing carers to make their own decisions because the cared for person is insisting that everything is around them. Economic or financial abuse can include things like benefits and making sure that benefits aren't accessible or they're taken and used for other things. And also psychological abuse that can include things like what we term as gaslighting. So saying things like, if you tell people what's happening, they're not going to believe you because you know, I'm in a wheelchair, or those kind of things that are emotional abuse, but also have some control element to them as well. And also things like if you tell somebody, then they'll put me into a home and then it will be your fault, those kind of threats and emotional control. So the Domestic Abuse Act sets out these behaviours and also says that domestic abuse is between persons that are personally connected, And the definition of personally connected includes partners. It also includes ex-partners to recognise that abuse can continue after a relationship has ended, and also relatives. So when a carer is experiencing domestic abuse from the person that they're caring for, it's important to recognise that that abuse may have actually been going on for a long time. It may be that that person has been abusive for the entirety of that relationship. So therefore, it's important to consider the historical aspect of that abuse. But equally, it may be a new behaviour. It may be as a result of an illness, such as dementia, behaviour changes with that, or the fear and worry that being diagnosed with dementia has. It could also be a side effect of some medications. So carers can be very isolated. There are usually restrictions on the time that they get to spend away from their family and from the person they're caring for, often little contact with friends or family, because the majority of their time is taken up with caring. I mean, if you think about the carer's allowance limit of 35 hours a week, that's the same as a full-time job. And I think, that's often a very minimum that people are doing. So there is very little space for them to have time for themselves. Feeling controlled into providing the care can also be an aspect of the abuse, and that they feel trapped because they're having to provide that care. And carers will often lose their own identity because everything becomes about caring for that person and meeting their needs, and particularly if that person is abusive and very controlling, then it's even more about that person. And carers can also, as Sarah mentioned in her presentation, be worried about the consequences if they do actually speak out and ask for help. So some of the specific risks to carers are the close proximity of delivering personal care, things I just mentioned, physical violence, but also sexual abuse, unwanted sexual touching whilst they're delivering personal care as well. The emotional abuse and control, and feeling that they can't leave, as I've already mentioned, and also being emotionally controlled into being told that they can't leave. And with the isolation, as I just said, carers are often very isolated, but isolation is also a sort of type of abuse that's used by abusers to isolate their victims. So in the case of carers, they can actually experience double that isolation. So if a carer does decide that they feel they need to speak to somebody about the abuse, first of all, there are issues around who they could actually speak to. It may be that there aren't any other family members around. There may not be actually any professional organisations or agencies involved with the person they're caring for. And they're likely to be very worried about people thinking that they can't cope with the carer role if they speak out about abuse. The guilt, which Sarah also mentioned, particularly if the abuse appears to be as a result of an illness or medication, actually talking about it does make the carer feel quite disloyal to the person that they're caring for. There can also sometimes be cultural expectations. In certain cultures, it is an expectation that younger members of the family will care for older members of the family when that time comes, and they could feel that they're very pressured into doing that. So speaking out against it will alienate not just people within their family, but maybe people in their wider community as well. And there's also the worry that the person that they're caring for might have to perhaps go into a care home or nursing home, or might have to have agency carers come into the home who would be strangers to them. And there's also cost implications for having agency carers or having to go into a residential home. So there are a lot of considerations there. I personally think, and speaking to some carers that I've spoken to about this, that there are probably more reasons not to speak out about the abuse of your carer than what there are. So in terms of support for carers, we have a carers assessment that should be offered to all carers. That's part of the Care Act 2014, that all carers are offered a carers assessment, and that's to assess their needs in their own right. But Carers UK, from their last year's State of Caring report, found that only 25% of carers had either received an assessment or been reassessed in the last 12 months. There can also be an issue there that the carers assessment is sometimes carried out at the same time as the assessment for the cared for person. So they're in the same room, so they're not actually able to discuss if perhaps there has been historical abuse or they are worried about abuse. They can't actually discuss that confidentially. GPs are able to register people as carers, and they are also able to link the records of the cared for person and the carer, if they're at the same address, on the computer system. So that should flag up any issues that they come into, either of them come into the surgery about, that may indicate abuse. But unfortunately, that linking of records isn't consistent. And also GPs are able to signpost to carer support agencies, but again, that's not being done consistently in England at the moment. And there are also carers surveys like the one I've mentioned, the Carers UK State of Caring survey. There are also surveys that come out from NHS Digital that go through local authorities to distribute to carers, but none of those surveys actually ask about any kind of harm or domestic abuse that could be happening to the carer. I appreciate that that might not be the right mechanism to ask, but it's not even a consideration. So I've just got a couple of, they're not really case studies, it's just sort of some brief information on some of the cases that we had in Cambridgeshire that led me to start looking at this topic. And the reason I can only give brief information is because there are going to be domestic homicide reviews published, but they haven't been published yet, so I can't share too much information. But in one of the cases, it was an elderly couple in their 80s. Both of them had been diagnosed with dementia. They were in a mutual caring relationship, they were caring for each other, but the wife was actually quite verbally and emotionally abusive to the husband. There were some issues around injuries to the husband and also around medication, whether it's being taken appropriately. Unfortunately, in this case, the husband, Mr. K, took his own life. And in the note that he left to it, his suicide note, it actually said that it was because of the abuse that he had been experiencing and trying to work through that abuse but still care for his wife. Interestingly, in that case, both of the couple were self-funding, so they didn't actually have any involvement from adult social care, and they had very little involvement from any other agencies either. We also had a very similar case, Mr. J, who was caring for his wife. There were significant concerns around her mental health. Several reports were made to the police and also to social care. Mr. J unfortunately refused support around the abuse. He declined all offers of support. And again, this man who was in his 80s took his life. And then very recently, we've had a case of a man who had been caring for his son, although none of the agencies involved with his son knew that the father was actually providing the care. It was much more the emotional type of care because his son had significant mental health concerns, and his son actually killed him earlier this year. So they're just sort of some of the examples of some of the cases that have come up. So Sarah and Nikki mentioned safeguarding and legislation. So we do have the Care Act over here, which was the first thing that put adult safeguarding on a legislative footing. And I think a lot of professionals who had worked with the very ad hoc arrangements around adult safeguarding prior to the Care Act were quite pleased that it was going to be sort of set in stone, really. Unfortunately, the criteria that people have to meet around adult safeguarding is fairly strict. So they need to meet criteria to be an adult at risk, which means that they have to have care and support needs, and that's whether those care and support needs are being met or not. But those care and support needs have to be significant enough that they stop them protecting themselves from abuse. So in the context of carers, most actually don't meet that adult at risk criteria. So it's probably likely for most carers that they do have support needs, but the majority of them will probably not have care needs. So they don't meet that part, but equally the really key thing is about whether they can actually protect themselves from that abuse or not. And in the case of a carer who doesn't have care needs themselves, actually technically they could protect themselves from the abuse by stopping doing the caring. Obviously in real life it's not as easy as that, but that does mean that they don't qualify for that adult safeguarding support. And even where family carers do qualify under adult safeguarding, it may be that they prefer much less formal options than going down that adult safeguarding route, which can sometimes involve reporting to the police and things like that. They may prefer not to go as far as that with their support. So another process that we have is the domestic homicide reviews. So domestic homicide reviews are a multi-agency review that is carried out either when somebody is murdered by a family member or a relative, partner, ex-partner, or when somebody takes their own life and it's known or found out in the aftermath that they were experiencing domestic abuse. So the domestic homicide review is carried out to determine any changes to practice and policy that could be needed from any of the agencies that were involved with either the victim or the abuser. So the Home Office have started in recent years doing some thematic reviews of domestic homicides that are submitted to them. And the latest data that's published, there is a new report that I have seen, but it's not published yet, so I can't share the data on that. But the latest data looked at 108 domestic homicide reviews that were submitted to the Home Office from October 2020 to September 2021, and of those 108, the carer was the victim of the murder in these cases, in 10 of those cases, and out of those victims only one had a carer's assessment. But it's not actually known if the others were offered a carer's assessment or not, but certainly the take-up of carer's assessments was only one of those victims of homicide. And the themed report also identifies some of the risks around domestic homicide, particularly in relation to carers. So they have flagged that either the carer or the cared for person having mental health issues, mental ill health, is a significant risk. substance misuse for the person being cared for. There's also not very often a consideration by agencies of any previous abuse, and the risks there aren't taken into consideration. There's very little consideration of the suitability of somebody to take on a carer role. And also there is a risk around if the people are self-funding. So if they aren't receiving any financial support from the local authority, they are pretty much invisible, really. So that is a quite significant risk for homicide or suicide. So some of the solutions that we're looking at through the work in Cambridgeshire are, first of all, explaining what domestic abuse looks like to people, going back to that terminology. How do people, how would people refer to what's happening themselves, and make sure we use the words that that sort of resonate with people. We're also recommending that domestic abuse is included in carers' assessments and carers' surveys, and that those are done in a way that the carer can actually speak about what's happening without the cared for person being there with them. We're also, we have carer strategies across local authorities and health partners, and we're trying to get domestic abuse included in the local carers strategy, and also the individual agencies include it in their policies and their operating procedures. We're also looking to try and get some specific training around domestic abuse and carers. It's often, we find things like that are often subsumed into general safeguarding training, but as I just explained, carers often don't meet that criteria for adult safeguarding. So we're asking agencies to consider delivering specific training around carers as victims of domestic abuse. And then finally, to do some awareness raising amongst both domestic abuse services about the complexities of the caring relationship, particularly around the type of support that domestic abuse services can offer. Very often domestic abuse services will offer short-term, quite task-specific support that is often based on an outcome of that relationship ending in order to keep the victim safe. But actually, in the case of carers, they may not actually want that relationship to end. It's more likely that they want the abuse to end, but they want to maintain their caring relationship. So looking at different ways that that can be done and adapting safety planning, but also working with carer support services to raise the awareness of domestic abuse so that people can feel that they can come forward and ask for support, and that the support they get is actually going to understand the situation they are actually in. Once all this is in place, then we're hoping to do some work around increasing public awareness, because obviously there's no point saying, you know, raising public awareness and saying come forward for support if actually the support isn't appropriate at the moment. But just a final note to say all these things are needed, but we're sort of in a bit of a circle at the moment, in that there is, in order to get services, we need funding, and for most funding, you need evidence of the need for a service. And we're sort of a bit stuck in that circle at the moment. The evidence isn't there, so you can't get the funding, and it sort of goes round and round. So we're at the moment trying to sort of break into that circle a bit and see where we can do some sort of smaller scale work to try and demonstrate the need for specific support for carers. And yeah, that's the end of my presentation. So I'm happy to take any questions or comments.
Thanks so much, Amanda. That was a really, really interesting and rich presentation. I think you're referring to homicide reviews and suicide has really brought home the seriousness. Of course, that was really evident in Sarah's presentation as well. But yeah, it really is showing the kind of hidden and very dark side of care, and the importance of very clear pathways of supports for carers as well. And we're in the Irish context, we're very similar in the sense that there doesn't seem to be a way of recording this to kind of show evidence, and like you say, that's connected to funding then as well. So it will be interesting to talk to our other panelists if that's the same in their jurisdictions. And I'd like to open the floor to questions. If anybody has any questions for Amanda, you can put it in the Q&A or raise your hand to ask a question live. There doesn't seem to be anything coming up just now, but perhaps, Amanda, I can use my privilege as chair then to ask a question. Just around the use of language, I guess that this is something, as Sarah said, we've been grappling with in the report where this kind of, we're in the survey that brought this to light for us. When we reported it, we did actually use the term abuse, and at the time I was very uncomfortable with that term because it implies intention, and has, you know, that there's the risk of further stigmatizing already stigmatized group of people, you know, people with disabilities, people with dementia and so on. And so we moved then towards care harm, and as Sarah says, that's not, abuse is kind of a bit more recognizable, I guess. And I just kind of, I'm wondering if you've grappled with that yourself in terms of how you think about intentionality and the connection with abuse, and yeah, I'm interested in your thoughts on that.
As I said, it was something that we spoke to a carers group about, because I was very conscious that I'm a professional, I'm not a carer, so the words and terminology I use won't necessarily resonate with carers. And also in terms of people who've experienced domestic abuse in general, they often don't recognise themselves as victims of domestic abuse. So it was a conversation that we had, and it was really that we decided we would focus mainly on deliberate abuse, that we decided to use the term domestic abuse. But while also sort of having a side note of sometimes where these behaviours are caused by illnesses, actually that may not be deliberate, but we didn't want to, I guess the other side of it is putting too much emphasis on unintentional abuse, so that people then will always assume that, well, it's that they're behaving like that because of dementia or because of medication, and the assumption that people with dementia are always aggressive, and which obviously isn't true. So that was, yeah, it was a quite complicated conversation. We did change the name of the project to Carer Harm at one point, but then you know, we went back to domestic abuse. But I still don't know if that is the right term or not. I think it's more about when we, rather than just using the word, explain those types of behaviours, I think is the key to sort of the understanding.
Great, thanks, Amanda. And this might be picked up again by our other panelists in the panel discussion. And thank you so much, Amanda, for that, and really appreciate your time this morning. We'll move on to our panel discussion. There's no other Q&A or questions there. So we'll move on to the panel discussion then. So we have Amanda and Sarah also speaking this morning. We also have Professor Alison Milne and Dr. Maria Nilsson here this morning. So Alison is a professor, emeritus professor of social gerontology and social work at the University of Kent. She's a registered social worker, and Alison has taught in undergraduate and postgrad qualifying social work programs for over 10 years. She's supervised MA dissertations and continues to supervise PhD students. Her research interests are in 4 intersecting areas: social work with older people and their families, mental health in later life, family caring, and long-term care. So it all very relevant to the discussion here this morning. Alison has done funded research in all 4 areas and is widely published on that in the areas as well. Alison was a member of the Research Excellence Framework 2021 sub-panel for social work and social policy, and the Standing Commission on Carers. She's a fellow of the Academy of Social Sciences as well. I'll also introduce Maria here. Maria Nilsson is a practitioner and facilitator at the Swedish Family Care Competence Centre and a lecturer at the Department of Health and Caring Sciences at Linnaeus University in Sweden. She has a background as a registered nurse and holds a master's degree in caring sciences. Maria's PhD thesis, which was recently published, focuses on the driving forces behind the implementation and use of digital technology in the care of older people and the consequences for older people and their informal carers. She will shortly defend her thesis at a public defence at the university on the 16th June, so very, very soon. And we wish you all the best with that, Maria. And Maria has led projects in the area of informal carers, care and caring, and has facilitated public hearings, written policy responses to the government regarding legislation, proposals and inquiries for supportive carers and health and social care issues. So with that, I will open the floor to yourself, Alison, just to kind of give some reflections from your perspective on both talks so far and on the topic of care harm. Thanks, Alison.
No problem. Thank you very much indeed, Nikki. I've got quite a few points, actually. I mean, the first thing to say is I think, obviously, the issues are complex. They're nuanced and they're highly emotive. And carer harm, well, I'll come on to the linguistic challenges in a second. It straddles the private domain of the family and the public domain of sort of agencies having some duties and responsibilities in relationship to care and support often of the person who's being looked after. And sometimes the carer, but also in the UK under the sort of safeguarding brief that Amanda was referring to. I mean, there are lots of different types of harm, aren't there, in abuse? And there are also lots of different types of relationships. And the life courses that people have experienced, both individually and jointly, are also relevant. And Amanda was identifying the fact that abuse can often precede care. So again, that's another distinction, that domestic abuse may in fact be a lifelong issue in a marriage, and it may start after caring, or it may continue post-caring, or it may be a new challenge. And then the other dimension is the intentionality issue, which again, you've both touched upon, which I think also is complicated and can be quite a challenge to deal with. It's a very hidden issue, isn't it? I mean, you've all talked about that. It's unacknowledged, it's taboo, it's stigmatizing, it's associated with guilt and people not wanting to talk about it and not wanting to acknowledge it. And yet it's there and needs to be considered. I mean, none of us really want to talk about it. It's clearly an issue we're beginning to open the door on, very importantly. Then the linguistic challenges are myriad, really, aren't they? The language that permeates public and policy narratives struggles with the harm and abuse discourse, doesn't it? Because it sees caring as almost entirely positive, as carers as willing and always able and always competent to do caring, unsupported. Carers are quite often rather idealised, they're constructed as heroes. And that's a challenge aligning or next to or seen as you know, alongside the concept of carer harm or carer abuse. And carers, of course, are seen very much as a free resource. We rely on them. I mean, policymakers openly love carers because they're free. And carers, of course, struggle often, however challenging care may be, to ask for help. It's often seen as not coping, as not managing. And good luck with getting help. I mean, we've heard from both speakers this morning how challenging it is to get help. The system is opaque, it's fragmented, and that assumes you've already identified yourself as a carer, which, as we've already heard, a lot of people don't. So it's very hard to get help, even if you think you might need it. I think we don't give carers permission in practically any practice context, actually, to say, I am struggling, I am finding this very difficult, I'm really at risk of just not managing, or of lashing out, or of being so exhausted that I accidentally give the person I'm looking after too many sleeping pills, I don't think we allow carers that space, that safe space to talk about the challenges of caring. And we haven't got a very good system of responding either. I mean, I'm not very keen on the whole safeguarding agenda, as Sarah knows, because it's just clunky. It's clunky. It's in the moment. I'm not against it as a method, as a model, as a way of thinking, but I don't think it suits or is fit for purpose in relationship to the issues we're talking about carers, which are embedded in a relationship, often complicated, often dyadic, and may have long roots that stretch way back into the life course. And I don't think safeguarding is particularly good at that. We've got a language of needs and risks, not rights and justice. I think we need to shift the lens towards rights and justice. We could consider reconceptualizing care, family care, as a social risk. Fiona Morgan writes about this and talks about the fact that we acknowledge that childcare is something the state shares to a limited degree, I completely acknowledge, with parents. But at least it admits it, acknowledges that parental leave, used to be called maternity leave, parental leave is something that employers, that parents have a right to, and some funding from the state. With family care, it's entirely a private responsibility to manage care. The state takes almost no responsibility for the social risks related to caring, including the consequences of it. I've made the point about caring being embedded in a relationship, and I think often what carers would benefit from is to have a proper, time-rich, trust relationship with a professional, not someone sweeping in to do an assessment for 5 minutes or to do a safeguarding assessment. They might tell you they're struggling if they trust you. We need to give carers permission to speak about distress. Isham et al. Talk about silencing practices. Both of you have talked about family members and professionals not really wanting to hear how difficult it is. So often relatives will say, oh, I'm sure dad's not that bad. When actually dad is that bad. But the son or daughter doesn't really want to hear that. So they would describe those as sort of silencing practices. I think carers have a right to be protected. And we don't seem to be able to be doing that at the moment. It reminds me a bit, some of the discussion we're having, of how domestic abuse was regarded 25 years ago, or even more recently. Let's not talk about it. Let's just shut the door on it. We don't need to think about it. It's a private issue. Now, think how far we have come, and some would say nowhere near far enough in that regard. And this discussion reminds me a little bit of some of those sorts of issues. I'm coming to the end, by the way, Nikki, in a second. I think there's more conceptual work to be done. I was very interested to hear what you said, Amanda, about the issues. It's coming up, isn't it, in safeguarding issues? It's beginning to rear its head. But we need to perhaps think about that and look across the system broadly, how carer harm and abuse is appearing. How is it appearing? In what guises? In what ways? And the feminist ethic of care that you mentioned at the start of our discussion, I think, Nikki, I think that has something to offer us, as does the life course lens, in my opinion. So there's much more work to be done conceptually. How do we think about this issue? And let's be honest, if we want to deal with this properly, it's going to cost money. We just shouldn't duck that issue. It will cost money to support carers properly, and to treat them with respect, and to protect them, and to support the person that they're looking after. It's going to be a growing issue. We expect so much for family carers now. They're looking after people that would have been in care homes or even hospital wards, and they're doing complex, intensive, often quasi-medical care tasks. And the risk of exploitation of carers, I think, is really, well, we're here, we're doing it. And I think we're going to see more of this issue. It's not going anywhere. We're abandoning them, I think, I would argue. I'm not a fan of the mandatory actions unless it comes with care and support guaranteed. And both of you have mentioned that, particularly you, Sarah, in your talk. There's no point in having abstract rights to stuff if when you turn up for them, there's nothing in the shed. There's nothing in the garage for you to have. There's no services for you to access. The that might be me, actually. Oh, yes, I did wonder whether there were any lessons from child protection, actually, in terms of thinking about some of the complexities. Family group conferencing, for example, might be a model might be helpful. I think that's me. Thank you, Nikki.
Thanks, Alison. That's really rich, and I think a really good overview of all of the different threads really that need to be considered. And I think it is quite interesting to think about this as when you say it reminds you of where domestic abuse was 25 years ago, and the kind of difficulties in talking about it. It is a very private thing. It is a very sensitive issue to talk about, and we don't really have the tools just yet for that. But this conversation is part of that. It's just kind of bringing it to light, isn't it? So thank you for that. Maria, I'll move on to yourself then, if that's okay. Thank you.
Yeah. Yes, thank you very much for inviting me. My name is Maria Nilsson, and I am a PhD student actually for one more week, and then hopefully out on the other side. I'm a PhD student at the Swedish Family Care Competence Center in Sweden. And we're a center of knowledge dissemination and center of excellency working on commission from the government. And we are a resource center for regions and municipalities in Sweden that works with, as we say, informal carers, but I know you use the word of unpaid care, so I should try to stick with that in my presentation. A big thank you to Amanda and Sarah for really exciting presentations and emotionally engaging, I think, when I was listening to them. I have some reflections, and then I also have some questions that I hope we have time to discuss together. From a Swedish perspective, I was just thinking, are there any similarities? What are the differences? And I think the similarities are there entirely, really. I think I recognize everything you say. That is the same situation in Sweden for the unpaid carers in Sweden, both in terms of the families with children, which they are on the autism spectrum, as well as family carers or unpaid carers for people on the dementia spectrum with various diseases with dementia. Just quickly, we have in Sweden, we have around 15 to 20% of the population 18 years or older that provide help, care or support to another person in need. And it's important to remember that about 1 in 4, around 25% of the unpaid carers in Sweden are themselves 65 years or older. And I think that is, you can easily forget that because we often talk about an older population as in care needs, but they provide a lot of help and contribute really unpaid to the society. I was thinking about from the Swedish perspective. As you all know, we've had a rather successful social experiment in Sweden that we call the Nordic welfare state, which I don't know if we can call it that is a memory from the past now, because our welfare state system is under tremendous pressure and we struggle to keep it going, really. And in terms of unpaid carers, it's important to know that the recent reform in Sweden that we call good quality local healthcare, they are moving the focus to get more home care really for everyone. People should be cared for in their own home. And as we all know, in the home are the unpaid carers 24/7 in many times. So in Sweden, we are also moving in a direction of that we expect to be more unpaid carers and need of more informal care. On the other hand, the recognition of unpaid carers has increased from being almost none in the 80s and 90s. People are now starting to be aware of issues around unpaid care, and we have last year we had this new guideline for informal care that the municipalities need to support them, and also the health and social care should provide support for unpaid carers. So that's it around the general situation in Sweden right now. And I was just having these reflections, and I perhaps might be around more of my area of older people when it comes to dementia. We have discussed a lot of it already, but we had this interesting newly published article that discussed the guidelines that are provided for unpaid carers of people with dementia, and analyzing how are we providing this support for unpaid carers? What expectations are there implicitly in these guidelines? Because the guidelines, they highlight the situations, even not that clear perhaps, but they address the issue of, verbal aggressions and so on. But how do they speak about it? In many times in our guidelines, at least, the unpaid carers are expected to cope with this, and they are expected to take care of themselves, and to, looking after both the person with dementia and their own needs. But what is that saying from the society? Is it really up to yourself to do all this, and where can you find help? Sure, you can apply for assistance, you can apply for home care, but I think there is a huge gap also in Sweden, where people go all the way down to where they cannot take it one more day, and then they apply for help. So that's just one of the recent things I thought that might be interesting to look at when in the support system. How are the communication what is it saying, and so on. So just a couple of questions. I thought first for Sarah, perhaps. You had these two groups based on diagnosis, autism and dementia. I wondered if you could provide some comments on those two groups, and not were there any thoughts around exclusion of other groups, for example, people suffering from mental health issues, or brain injuries, or so on, because that's also groups that might be affected. And also I was thinking about socioeconomic position. Could there be any differences between unpaid carers socioeconomically higher position? In Sweden, we know that there is quite a difference between those who access services and those who don't, for various reasons. I think that, and what your suggestions would be for future policy to change, perhaps. And before I can also ask the questions to Amanda, perhaps. I thought it was really interesting that you really underlined and emphasized how we need to ask these questions to the unpaid carers separately, and I will bring that with me. What would you say would need to change in policy? And I think the focus was rather much on the caring situation, but are there any environmental or contextual factors that you can see that could provide support or might be worsening the situation? If we look at the more societal perspective, are there any societal factors that could play a role? Because I think many times we get into this focus of the unpaid care and the person being cared for rather isolated. So that I think that if we can start by that. Thank you.
Thank you, Maria. And I think you've given us a really useful insights into the Swedish context and some of those kind of parallel issues. I think you've kind of given me three different questions, which I'll try to answer individually. In relation to your first question about I suppose, our sample or our target sample in the understanding care harm, I think for us it was kind of an not an accidental sample, but we focused on the people living with dementia and the carers of children or adults with autism, because that was the cohort that had come through very strongly in the original 2019 survey. So we didn't, I absolutely agree. Like, I think that we need further research looking at those carers of people with mental ill health or mental illness, but also people with acquired brain injury, because I'm imagining, drawn on my own practice experience, that there are some very similar issues. So again, I think that's work that needs to be done, but it didn't really, I mean, some of the broader issues would have come up in the focus group discussion, but we didn't really, as I said, have really dig into those areas, unfortunately. But I think there's definitely work that needs to be done there. In relation to the social capital issue, yeah, that was definitely a feature. And while our sample size was really small, like I think my sense was, and Nikki, I think you'll agree with me, like those family carers who were better educated, had accumulated more financial capital over the life course, were better equipped to try and navigate some of these situations, to access private care, private diagnosis, but also that they had the, I suppose, the educational underpinning and those kind of social capital resources and contacts that they were able to advocate for themselves and amplify their issues. So again, I'd love to see more work done on that, but that was definitely a feature. In terms of the policy piece, I think I'll revert to some of Alison's points in that. And again, this is probably me as well. Personally, I feel very strongly that this should not be going down the safeguarding route. Now, that's not to minimize in any way the harm or abuse that people are occurring, but I think this really needs, as I said, community-based, relationship-based, longer-term intervention and support. That ability of a social worker or a nurse or some key professional to build that trust, create that emotionally secure environment where the family care ultimately feels safe and comfortable opening up about what's going on. And certainly in the Irish context, we kind of have our policy responses are either go down the child welfare and protection route if there are younger children in the house, or conversely safeguarding. As I said, certainly from our work, that was not wanted and that was not welcome. So I think we need significant policy reform to better meet the needs and support family carers in these really difficult situations. So I hope that's kind of answered your questions, and I might hand over to Amanda because I know you'd a few for her as well.
Thank you, and thanks for your questions. So in terms of what might be making the situation worse, I think as a professional and also as a sort of member of the public, there's often media stories, NHS is in crisis, social care is in crisis, and some of that is due to financial issues, the economy. There's a lack of social care staff, a lack of NHS staff. So I think there is a sort of view from carers that even if they asked for support, it's not there anyway. And I think that is sort of making the situation worse at the moment. As regards policies, I agree that adult safeguarding isn't the best route. Obviously, the adult safeguarding legislation we have under the Care Act doesn't help. I do think that more discussion like this needs to take place to sort of raise awareness of those issues, and that long-term funding for support is one of the key things that's needed. So many interventions are sort of a need is identified and then you get like a year's funding, and no sooner has the project started to sort of have some benefits than it stopped, and the people who needed the support are back having nothing again. So I think it's about investing long-term funding, but also investing that in support that carers identify will help them, not policymakers deciding what they think will help. Actually properly involving people and not just ticking the co-production box and say, well, we sent out a survey, or we asked on Facebook, or whatever they do, but actually properly working in partnership with carers to find out what will help them.
Thank you very much, both of you. Very interesting to hear. And again, it's I can see the resemblance very much. Thank you.
Thank you, Maria. I'd like to ask the floor, or open up the floor to questions. If anyone has any questions for any of the panelists, you can pop them into the Q&A or raise your hand. In the meantime, I'll go back to Alison's question. Sarah, you raised the point around child protection, that that's one route to go down. And Alison asked, is there any lessons to be learned from child protection in terms of models of support, or perhaps maybe we can talk about, actually, are there any best practices out there in supporting carers who are experiencing this issue from your country?
There's probably lots of things we can learn from child protection in terms of what not to do, I would say, as well as to do. But I think for the Irish study, what was interesting is there's one modeler approach. It's called MEHL. It's an Irish name, but it's essentially kind of a child welfare intervention that involves, so it's kind of a precursor to things getting to the abusive stage. So where there's concerns about the welfare of the family unit or children within that this kind of wraparound intervention would be offered to the family. And as I said, it's not routinely offered in these situations. Some of our family carers spoke about it being very helpful. And again, I suppose I wonder about that kind of whole wraparound family kind of holistic approach, which sounds very aspirational and ideal and doesn't really exist probably in most of our systems, but I think that's probably ultimately what we need here. But Alison, I can see you're unmuted, so maybe you want to come.
So I suppose I would just agree that the trouble with constructing it as a safeguarding issue is we're not going to repeat the stuff we already said. I generally don't think that's the route to go down. Of course, there are safeguarding issues. It's not that that's not a reality, but as a model, it is probably going to drive carers away from the system, not into its arms. And I think the care and support route's got to be the way forward. And I think child protection, certainly in the UK, has such a bad press, and it's so stigmatizing. It's seen as a complete rank failure on the part of a family if they end up in the arms of child protection. And I would really worry about kind of, as it were, going down that path. It's got to be a care and support agenda that's going to help carers, not an agenda where people are sort of seen to be not coping as opposed to not being supported properly. I mean, I would change that whole kind of way of framing it, I mean, of course they're not coping, particularly as you raised, Maria. A lot of now there's aging of caring, more carers, increasing proportion of carers are now age 65 or over. So we've now got the really troubling sector of people in their 70s and 80s looking after someone of the same age or older, struggling to bath and handle and dress and manage somebody who's resisting and doesn't recognize them anymore and might have dementia. It's really it's a really quite a challenging world, a challenging agenda. And instead of saying let's think through how we can make this something that's actually going to protect both people in that situation, we wait until the carer doesn't cope, and then we kind of might come in and say, well, put your relative in a care home. It's not, it's really not very good. It's really very poor, and not caring for the carers one jot.
Great, thank you, Alison. Are there any more questions from the floor? No, okay. Well, maybe I'll just sorry, Alison.
Yes, I wanted to ask a question of everybody, really, including people who are taking part in the seminar, participants, about how the third sector organisations in the care, because as we all know, the third sector does a massive amounts of support of carers. I mean, really a lot, and often in the UK is commissioned by local authorities to do carers assessments under the Care Act. And I just wondered whether there were reflections from people who've worked in that sector, including yourself, Nikki, on how this is perceived and managed and dealt with and spoken about, and how much is it sort of recognised, I guess.
Well, it's not really, to be honest with you, Alison. Like it's on our radar because we have like a a network of carer support managers across the country, and they're working directly with carers, supporting them through, like I said at the beginning, you know, it could be for just rights and entitlements and information and signposting, right up to, you know, we provide free counselling, emergency respite and so on. And quite often that's how the kind of issue has kind of come onto our radar through that and the 2019 survey that we were recognising, and especially actually during COVID when services were pulled, it increasingly became an issue when people were, you know, at home, you know, caring for the person full time, and the person that needed care just out of their routine completely, and you know, lots of responsive behaviours to environmental changes and so on, leading to carers coming to us in crisis. And there was just nothing there. Like, we are a charity and we provide a whole lot of supports, but this is more systemic, as Sarah is talking about. It's there's issues there. You know, we can support carers so far, but we're a small organization. As you know, we have national reach and national coverage, but a lot of these issues, you know, if people had access to respite on a regular basis, appropriate services, it is about the, and as Sarah pointed, especially, well, I think it speaks to the dementia carers as well as the autistic group, with the lack of appropriate and timely assessments and interventions. You know, in the Irish context, certainly, like, you know, it's so poor. You could be waiting years on an assessment of need if you're a parent of a child with additional needs, and they get that assessment, and then, you know, they go on another waiting list. So yeah, so it's bigger than our charity, but I think this is certainly bringing the, like, you know, it is right. We've had discussions with other groups like the Alzheimer's Society around this as an issue, and I know they've recognized it as well. And I know Sarah has done some work with the Dementia Carers Campaign Network. You know, they've fed into the information materials and leaflets as well. So it's there in terms of the support that we're providing, but also, you know, we can only do so much. There's much broader and bigger responses required.
I mean, one of the pieces or the dimensions of the context that you were talking about, Maria, you talked about context and what is it? Are there differences? One of the issues of context is what support does the person they're looking after get? So sometimes carers are exposed to much higher levels of risk because the person they're looking after's had services removed by the local authority because they've had to cut back on. So kind of who's caused that problem, who's created that risk, you know, question.
Yeah, and the risk, like you said, it's all fallen back onto the, you know, the private individual, the private households. It's not kind of, you know,
shared.
Yeah.
Yeah.
Either Sarah, you want to come in there?
No, I just want to come at the end. I think Maria raised it as well. Like, to me, I think there's a bigger, you know, there's the services issue, there's the funding, but I think there's also societal attitudes issue, which is hugely, I suppose troubling in that, you know, I think we need to all move towards recognizing at some stage in everyone's lives we're likely to be a carer, and that kind of need for intergenerational solidarity and kind of, I suppose, acknowledging that as citizens of a society, this is something of common interest to everything and something that will probably impact on all of us in different ways at different stages in our lives. And really, it's that I think is probably more of an issue in terms of, I suppose, people voting with their feet and asking for what they need and what they want. And, you know, I think that disconnect in society around these shared experiences and needs is troubling, and I don't think we're going to solve that, but I think it's definitely a factor as well. You know, until it's kind of directly affects you, people tend to not get particularly interested or passionate about it. But I think this is something that will, as I said, impact, you know, the issue of caregiving will impact on all of us at some stage.
Yeah, I can just give a short comment there that I think you're right. I think we need to consider societal norms really for how we meet unpaid carers. I mean, we have an expectation of high productivity throughout the society. We have expectations of independence, at least in the Nordic countries. Everyone's supposed to be independent, fending for themselves and so on. And I think that's also something that we need to reconsider really how how we are to live as a society together. I mean, everyone can't be up competing, and I think that's that we have different ways, and everyone can contribute in their own way. Something like that. I might be unclear here, but
no, I think you're being very clear. I think you're right. There is a challenge about the language we use. We have this obsession with the concept of independence when, you know, for a lot of us at various points in our lives, well, we all depend on other people actually for a start, but this concept of interdependency, I think is, and I'm not the first person to say this by any means, is a much more healthy idea in terms of, particularly if you've got, you know, age-related health challenges. If you've got dementia, you're probably not going to kind of, as it were, recover from it. You can do lots of things to have, you know, lots of things can be done to support you and help you. But so I think you're right. It's we need to sort of stop obsessing with the idea that independence is the holy grail and can be achieved and is in fact the right thing to desire.
And we have a couple of questions and comments. One of them is, would universal income help? Which I probably can answer, but maybe I don't know if anyone has any thoughts on that. Well, just to kind of flag that Family Carers Ireland are working with researchers in Maynooth University on, it's not quite a universal income, it's something called a participation income, which is where people are financially recognised for doing socially useful work, of which caring is one type of work. And in terms of whether that would help, it would help in terms of, you know, people having access to financial supports. But what the report that's going to be published next week stresses is that financial support has to be underpinned by access to universal basic services. You know, people need services, and a service-led approach is extremely important alongside that financial recognition. So, yeah, if you want to, Sarah, who's asked this question, we will be launching that report next Tuesday if you want to keep an eye out on Family Carers Ireland social media and on our website as well. And the second question before we finish up, or comment, is from Bridget Penhall. The lack of recognition of the issue hinders developing effective measures and achieving policy changes. Society is quite willing to allow these situations to continue, as addressing these issues would require significant resources and effort. Ambivalence around caregiving and carers runs very deep. Norms and attitudes are crucial in this, as Sarah and Marie have said. Thanks for the webinar. So that's, I think that comment actually captures a lot of the issues and brings together a lot of the threads. I was going to take some time to do that, but I think Bridget has actually done it very well. I think we have today really kind of broadened out the conversation from our last webinar. We have explored carer harm in its different guises, you know, talking about it in terms of physical, emotional abuse to that kind of much more systemic harm as well, when people don't have access to appropriate supports and services. And I think that's really important. I think this conversation, as Alison rightly said, this is possibly the beginning of, you know, a shift in how we discuss the idea of carer harm, or as Amanda calls it, domestic abuse as well. And I think it's really important that this conversation happened and that it's recorded and that it can be shared. But I also am mindful that, you know, us in the panelists and the speakers and everybody in the audience continues the conversation as well, and brings it into their professional or personal spheres to just raise awareness and really kind of, yeah, just keep thinking about this. So I'd like to extend gratitude to all of our speakers and to our panelists. It's been a really, really great webinar, and thank you for your active participation and thoughtful contributions. Sarah, if you want to finish, you want to kind of say any last words, I'll hand over to you. Thank you.
No, just again to kind of echo your thanks, Nikki, to thank Amanda in particular for a fantastic presentation and really giving us insights into the UK context, Alison, for your really thoughtful reflections, and Maria, likewise, it was so fascinating to hear about the Nordic welfare state and your experiences and thoughts, but also for our comments and contributions from attendees. Other than that, just to wish everyone safe home virtually, and we'll share all the resources over the next few days in terms of the recording and the slides and also the Understanding Care Harm resources. So thank you all very much, and we are going to stop recording.